Hello, I'm Dr. Adam Harris. Thank you for your interest in knee replacement via minimally invasive techniques. This film is designed to both answer common questions and also to give you information that everybody who is having a knee replacement should have. Total knee replacement is a treatment for end-stage arthritis. Now, arthritis is loss of the cartilage. The cartilage is the white stuff you might see on the end of the chicken bone. We have that on the end of all of our bones where there's a moving joint at that end. And so loss of that cartilage can happen by many different means, but once it's gone, it matters a little bit less how you lost it than that it's lost. And so the treatment for loss of all the cartilage in at least part of the joint is frequently a joint replacement. So when do you do a knee replacement? Well, you do a knee replacement when simple things don't work and the knee is starting to run your life. You shouldn't wait until such time as the knee has taken over your life, as then the rehab becomes more difficult. So I'm a good doctor, I'm not a magician. If you become a couch potato, I can't cure couch potato. What sort of symptoms will somebody have if knee replacement is one of the potential treatments? Well, pain with activity, sometimes pain at rest, and limitation of motion, and frequently deformity of the knee, where you might be more bow-legged or more knock-kneed than you were before the onset of arthritis. So what are the simple things? Well, there are 4 categories for treatment of any arthritic joint. There are injections, braces, pills, and exercises. Injections come in many forms, from steroid injections to stem cell injections. These seem to have some benefit for a patient who does not yet have end-stage arthritis. But once you hit bone on bone, injecting the knee with any substance is likely to increase the risk of problems at the time of the knee replacement rather than decrease them. Some patients are amenable to brace treatment. These braces tend to be a little bit heavy and a little bit awkward, and so younger men tend to be willing to wear the braces. The older ladies, not so much. But the concept of the brace is if you do not have a contracture, in other words, you can run your knee through a full range of motion, and the deformity from side to side is correctable. Then if there's not too much arthritis in the front of the knee, there are good braces. If you don't have all those criteria, the braces really don't work very well. And so I have very few patients who end up choosing brace treatment as an option, though I discuss it with everybody. When I refer to pills, I'm talking about 2 types of medications. One would be Tylenol, the other would be anti-inflammatories. Over-the-counter, such as Advil or Aleve, or many different prescription medications in the same class. And these are good pain relievers. They won't get back motion that's been lost, and they won't correct deformity. But if all that you need in order to maintain your level of activity is to take an anti-inflammatory on a daily basis, then you shouldn't be talking about knee replacements. The last treatment would be exercises. And there are a few forms of arthritis, or a few patterns of arthritis better, that are amenable to exercise. But these are limited, and if you're watching this video, probably I've already discussed them with you, and they're not a good option. Anytime one talks about surgeries, one has to talk about expected benefits and potential risks. So again, the potential benefits for knee replacement would be decreased discomfort, increased mobility, increased activity level. The potential risk of any surgeries would, if you list every possible one, becomes a very long list. But most of them are very, very infrequent. The ones that are measurable would be infection, fracture, and failure to relieve the discomfort. Infection in my hands is somewhere around 0.2%, maybe a little bit less than that. So uncommon, not zero. Any doctor who tells you he or she has no infections either hasn't done very many or is lying to you. Fracture is also an extremely rare issue, and later in this film I'm going to show instruments which I designed in part to diminish or eliminate the possibility of periprosthetic fracture around the time of the surgery. And then the last one I mentioned here was failure to relieve the discomfort. Again, in my patient population, these are few and far between, but knee replacements frequently will leave somebody with a little bit of discomfort, a residual that's a minor nuisance. People who completely forget that the knee has been replaced are a minority. These are models of total knee replacements. This is the model that I most commonly use. This is a model that's applicable to a few patients. In both of these examples, the clear plastic is designed to represent the bone, and the other pieces are representing the implants. So a total knee replacement is a resurfacing arthroplasty. Put a new surface on the face of all three bones. So the underside of the kneecap gets a new surface, the end of the femur gets a new surface, and the top of the tibia gets a new surface. Now, I like this particular design of knee replacements better than any other for several reasons. Number one, the materials. This is oxinium. It's a ceramic-like surface on a metal component, which gives it a lower friction and therefore lower wear. These materials have been bench tested for 30 years of simulated use and have stood up to it. Now, they've been in people for 20, and so far the materials are living up to their hype. Prior to about 20 years ago, the expected lifespan of a knee replacement was 10 to 15 years. Now to say that it's 20 to 30 is actually very reasonable. So silent problems or wear debris problems are almost gone. Unfortunately, not completely gone. So what is involved in the knee replacement? Here, first of all, I'll look at the other one for a moment. The natural knee is stabilized by 4 ligaments, one on each side. These are the collaterals, and then 2 in the middle that cross, represented by the orange threads here. These are the cruciate ligaments. And so this knee replacement retains all 4 ligaments. The advantage to this is that it's supposed to feel more like a natural knee. The disadvantage is that it seems to be a little bit more variable as far as outcomes are concerned. Just getting started with robotics to help diminish that variability. This knee, on the other hand, maintains both of the collateral ligaments, but mechanically substitutes for the cruciate ligaments with this post here, with the post here, and that allows posterior cruciate ligament function that way, anterior cruciate ligament function this way, again limiting abnormal motion. But what I like about the Smith & Nephew knees more than anything else is that they are the only truly anatomic implant on the market. Now, if you look carefully at radiographs or look carefully at anatomic sections of the femur, I'm going to take this off here. The condyles, which is a fancy Latin word for knuckle, are not the same size. That's true of the natural knee, but every other artificial knee, they're the same. Why should they be? These mimic the actual anatomic differences between the medial or inside and the lateral or the outside, and then make up the difference here in the piece of plastic, again mimicking the natural knee. So these are some actual components from the journey to BCS, or bicruciate stabilized knee. And you can see, or hopefully you can see, that the condyles are not the same size, and that the surface is oxinium, which is the ceramic-like surface on a metal-backed component, so that you get much less wear during the use. The backside has a cement interface. The tibial component is made out of titanium, again with a cement surface on the backside. And the fancy plastic piece here can slip on and lock in that way. I'm not going to push it all the way in because I don't have the tool to take it out. Then the patellar button fits on the underside of the kneecap so that you have, when it's all put together, oxinium on fancy plastic, either, and oxinium on fancy plastic here. The Journey family of components, though, comes in several different forms. So the cruciate sparing, or the XR component, which I showed you previously with the orange stripes, this is the tibial component. So there's space to maintain the cruciate ligaments here, and smaller pieces of plastic fitting in on both sides. So again, you have the oxinium on fancy plastic as a bearing. The third option for the BCS knee is a cement-less tibia. And this is a fancy, actually 3D printed component. Again, it's titanium with a roughened bone ingrowth surface and a little different configuration to allow this to sit in the femur without the use of cement. Now, the thought is that the cementless will last longer. In the hip, the standard of care is a cementless component, but in the knee, the designs have not yet been able to outlast the cemented designs, but this is likely to be the exception to that rule. And so this is cementless tibia, cuts down the operating room time just a little bit, and expected to last longer. There's also a cementless patellar component with a bone growth surface on the back and the same fancy plastic on the outside. The last two pieces here that I want to show is a unicompartmental replacement. Now in San Antonio, I don't see a whole lot of people who are good candidates for partial knee replacements. The knee itself has three compartments, one on the inside, one on the outside, and one in the front. And a total knee replacement replaces all three compartments. But if only one of them is diseased, then you can put in a replacement for the tibia here and for the femur here, and leave the other two natural parts alone. And again, that's supposed to feel more like a natural knee. The advantage to that, again, is it feels more like a natural knee. The potential disadvantage is developing arthritis in the other parts of the knee and needing it at a subsequent time to come back and replace it with a primary or sometimes revision total knee replacement down the line. I'd like to talk for a moment also about an instrument and part of the technique which I have now received patents, 2 patents from the United States Patent Office for knee replacements. This is the instrument. The other instruments here are part of the design. So what's unique about this system? One of the things that you do during a knee replacement is find the proper size. Now, this is a little bit like fitting the shoe in the shoe store. You put your foot in the guide, you measure it, and then the salesman takes out shoes of the proper size. Now, no matter how talented your surgeon might be or how well designed the implant might be, the odds of getting the implant exactly where your ligaments want it is close to 0. So the ideal size for an artificial joint is just a touch smaller than the original. But how do you put it where it belongs? And so there are tools that have been developed over years to help do that. But one thing which has been not well addressed by prior instrumentation is the position of the component in this plane. Okay? There are good ways to get it rotationally correct and angularly correct, but front to back has largely been ignored. That's addressed by this tool here. Now this tool has a sizing guide and a feeler gauge. But what is unique about it is once you make the cut on the front or on the top of the femur, the front side of the femur, I can measure it here and adjust the cut until the top to bottom dimension matches the front to back dimension, and that puts the component exactly where it belongs. I've also redesigned a few instruments such as this one to minimize the amount of force that's necessary to get the exposure to do the distal cut. I'm sorry, this is the original, this is the remake, and an aiming guide to be sure that you're in the right place for the distal cut. The last tool in this set here is the chamfer guide. As you can, if you look at the implant from the side, there are angled cuts along the way, and those need to be made with accuracy also. This is the only system that I know of that has two surfaces to anchor the cutting guide, and so then these other chamfer cuts or the angled cuts are made with greater accuracy and better fit of the implant on the bone. They're all designed to minimize the amount of force that's requisite to get the exposure to do the surgery and therefore minimize the amount of discomfort, but also to improve the accuracy of placement. And the more accurately the component is placed, the better the function will be after the surgery. Now, while there are several choices for implants, the implants that I choose or recommend are made by Smith & Nephew, and primarily because it is the only truly anatomic design that's on the market. This actually replicates the normal dimensions and normal proportions of a total knee replacement. And so while other manufacturers have wonderful advertising campaigns about being round, for example, round isn't the natural. So if you replace the surface of something that is not round with something that is round, that's abnormal. If you replace something which is worn with a fresh version of the same, you're more likely to get a better result. A frequent question that I get is, how soon after the surgery can I drive? So there isn't, unfortunately, a good scientific answer to this question. And if you think about it, there are lots of people out there driving right now who have no business being on the road, and they didn't just have a knee replacement surgery. What few studies are out there suggest that it doesn't matter hip or knee, right or left, but it's several weeks after the surgery until reaction times return to normal. Now, the consensus in the orthopedic community is about 4 weeks. Now, do many of my patients drive before 4 weeks? You bet they do. But if you drive inside of 4 weeks and you get in an accident, please don't say that I told you it was okay. After 4 weeks, then you have my blessing. An interesting question that many patients ask me is, how long is the surgery? To me, that's a little bit ridiculous, because to the patient it's going to seem like 5 minutes. That's called good anesthesia. It actually takes longer than that. On average, the knee replacements will take me between an hour and a half and 2 hours. But for the family members, that's not how long you're waiting, because the in-the-room time also includes time for anesthesia, time for nursing, time for the prep to get the skin ready, and time for bandaging and waking you up at the end of the case. Put that all together, and it's 3 to 3.5 hours. Now, with these less invasive techniques that I employ, the average hospital stay is really 1 night. Now, some people might be ready to go home the same day, but it's a nice hospital, it's a nice hotel. Staying overnight is usually not a problem. But the key point about when is it safe to go home, being a little bit facetious, if there were a fire in your house, would you be able to get your own rear end out of the house? I don't care if you have a spouse or a significant other. I'm not going to count on them to carry you out if there's such an emergency. You should be able to get your own rear end out. And when you can do that, then you're safe to go home. So it's important for us to know ahead of time what sort of barriers you have or obstacles. It's also important for you to plan ahead so that if you have throw rugs, or if you have narrow passageways, or if you have objects blocking easy access to important parts of the house, that you move them ahead of time. Get the house prepared. Also plan who's going to be helping you. Most people don't need a great deal of help, but it's nice to have somebody there if necessary. And if you really have no help, let us know ahead of time. We can help set some of these things up if they're needed. I've used the term less invasive surgery. Now, the term earlier, maybe 20 years ago, we talked about minimally invasive surgery. But that term has been so overused and abused that it begins to mean nothing. So the concept of less invasive surgery has 2 parts to it. Number 1, it's the opposite of what is a bit of a joke during orthopedic training. In orthopedic training, the joke is, if brute force doesn't work, you're not using enough of it. That's frequently followed by, well, if it breaks, it needed fixing anyway. Well, this may be true for certain orthopedic procedures, but the more brute force one needs to do the procedure, the more the patient hurts afterwards. And so if the same procedure can be done by subtlety and by positioning and by minimizing force, then the patient has less pain afterwards. So if one looks at this critically, I do all the same steps as far as the bone work is concerned that any good orthopedic knee surgeon would do. I don't do them in the same order, because another dictum of orthopedic surgery is you get your exposure, then you do your surgery. In the case of the knee, if you did it that way, you'd have to use brute force. So the way that I do the surgery is I've shuffled the steps so that step 1 allows me to see step 2 without needing brute force, and step 2 allows me to see step 3 without brute force. And in fact, what is my step 1 once I'm inside the joint is something that's usually done near the end of a traditional replacement. But by shuffling the order, I can get all the steps done without resorting to excessive force at any point, and all of this makes it less painful after the surgery. People will ask sometimes, how much pain will I have after the surgery? Well, I do things, and we're constantly improving on how to make it less painful after the surgery. One of the things that we do ahead of time is block some of the peripheral nerves that are responsible for a lot of the pain that you feel after the surgery. This has been in some cases so effective that the patient said, hey, I don't need the surgery, this is wonderful, my pain's gone. Well, those techniques last for about 3 months, and sure enough, these handful of patients have come back 3 months later, yeah, you were right, I do need the surgery. So that's one thing we do. We do a lot of other tricks as far as technique and medications are concerned. And so that I'm not going to say that knee replacements are painless. I have had some patients who have had no pain after knee surgery, but it's not the patient. I have at least 2 patients in my practice had no pain with their first replacement, and they hurt like everybody else with the second. One of these patients asked me what I did wrong, and I said, I wish I knew I did right. Now, people who have no pain is a slowly growing percentage, but it's still a minority. So one of the things that we do after the surgery is I give you pain medicine. Please don't be afraid of it. Knee replacements are partnerships, and if you don't do your work, it doesn't matter if I do a good job. And your work is to keep the motion that I get for you on the table. And if it takes some pain medication to do that, don't be afraid of it, take it. I've never made an addict. We'll get you off the medicine, take what you need so you can do the exercises. Now, this is usually not a great deal of medicine. And I know many other doctors in this community use much more powerful narcotics than the ones that I frequently use. And sometimes we don't need narcotics at all. But don't be afraid of them. Take what you need, do your part, and then you can expect a better long-term result. A few things that you can expect after the surgery is, one, that you should be walking the same day. And most people stay one night and then go home. I like people to go home because people at home need less pain medicine. And in fact, getting up and getting yourself to the bathroom instead of a bedside commode, or getting yourself to the kitchen for a drink of water, these are all things that are therapy and help mobilize and help minimize the discomfort, improve the function. So most people stay one night. So thank you very much for your attention. I hope that I have given you some good information about knee replacements, and I hope that I have answered all of the common questions. Thank you very much.